Good afternoon, and thank you for inviting me to speak today. Descriptions of the treatment of fistulous disease date back to the days of Hippocrates in 400 BC. However, the goals of fistula surgery have remained the same: to eliminate the fistula, to prevent recurrence, and to preserve sphincter function. Fistulotomy by most is considered the gold standard, at least for the treatment of intersphincteric or low transsphincteric fistula, with reported success rates of 87 to 100%. There are few randomized control trials on this subject, so most of the data that we have from the last 50 years is based on mostly retrospective single institution or multi-institution studies that have looked, as you can see, of a variety number of patients from 26 to 461. Now, most studies on this are plagued by having low length of follow-up, so less than 12 months of follow-up, which most people would say is not adequate to determine recurrence rates. I put together a list of studies that all had follow-up of 12 months or more, and as you can see, still there is a variation in the recurrence rates. These range from 1.5 to 39%. Now, it's difficult to compare these studies for a number of factors. The first is the description of the surgical procedure of fistulotomy. So in some of these papers, a fistulotomy was done at the same time as the initial abscess drainage, while in other papers it was done after the abscess had been incised and drained. It had then been treated by a ceton for anywhere from 6 to 12 weeks, and then definitive surgical therapy was done with the fistulotomy. In addition, the patient populations vary significantly. So in some studies, patients who had Crohn's disease or HIV were excluded, and we know that these are patients that tend to have poor wound healing and higher recurrence rates. In addition, the type of fistula that was studied varied significantly as well. So in some studies, they only looked at patients who had intersphincteric fistula, whereas in other studies, they included more complex disease, including extrasphincteric and suprasphincteric fistula. So it's difficult to really determine an exact recurrence rate. There's one study that I want to comment on, and it was from the University of Minnesota. They looked at a retrospective review of patients who had fistulas only from cryptoglandular origin from 1988 to 1992. They excluded patients who had superficial fistula that were associated with fissures, patients who had inflammatory bowel disease or hematologic malignancies, those with preoperative incontinence, and those who underwent fistulotomy at the time of initial drainage. They found 624 patients that met their criteria, and of those, 60% returned questionnaires. Their average follow-up was 29 months. As you can see here, the majority of patients had either intersphincteric or transsphincteric fistula. As you would expect with recurrence rates, the more complex the type of fistula, the higher the recurrence rate. Recurrence rates were also significantly greater if the internal opening could not be identified or if there was a horseshoe extension. And this once again speaks to a greater complexity of fistulous disease. In terms of treatment, most patients either underwent a fistulotomy with marsupialization or a ceton placement and then underwent a fistulotomy. There was no significant difference in these treatment types with regards to recurrence rates. On univariate analysis, they found that factors associated with recurrence were an inability to identify the internal opening, more complex fistulous type, horseshoe extension, if the internal opening was lateral as opposed to anterior or posterior, and then treatment, previous fistula surgery, and the experience of the surgeon were insignificant. On multivariate analysis, they found the factors associated with recurrence to once again be horseshoe extension, fistula type, and location of the internal opening. However, now they found that it was significant if patient, depending on the experience of the surgeon and previous fistula surgery. There have been a few randomized control trials, and recently there was a systematic review that looked at 21 randomized control trials comparing different surgical approaches for fistula and ano. The average follow-up for 5 studies, they had follow-up beyond 1 year. 8 studies had follow-up of 1 year, and 8 trials had less than 1 year. So once again, we're looking at a number of studies that have short follow-up, relatively short follow-up. 6 of these trials compared fistulotomy to other surgical techniques, and those are listed here. As you can see, once again, the number of patients varies anywhere from 13 to over 500. In those that commented on clinical resolution, they had a positive outcome in 89 to 100% of patients. When they looked at recurrence rates, they found anywhere between 0 and 12.5% recurrence. Now, this is lower than the recurrence rates that I showed you for the retrospective series, and I think that's because, as you'll see, the length of follow-up is short. So in some of these, they only looked for 2 to 3 months after the fistulotomy, and the greatest was 12 months. There are a number of alternative procedures that have been described. I'm not going to get into these because my co-discussants will, but they include fistulectomy, loose or cutting setons, endorectal advancement flaps, anocutaneous advancement flaps, fibrin glue, fibrin plugs, or the lift procedure. And I mention these just to point out that when there are over 100 different procedures described for one pathologic entity, none of them is perfect. Dr. Abkarian's group recently looked at their trends over a 25-year time period in the treatment of anal fistula surgery. Their paper included over 2,000 patients, and they grouped patients into those that had a cutting procedure, so either a fistulotomy or a partial fistulotomy, versus those who had a non-cutting procedure. As you can see here, for patients from 1975 to 1979, almost 100% of them underwent cutting procedures. This trend decreases over time to their most recent time period, 2005 to 2009, in which there's now a 50-50 split between those undergoing cutting versus non-cutting procedures. This linear graph just demonstrates the trend over time in the last 25 years. They also looked at the number of patients who had had more than one surgery, and what they noted was that in the initial time period, the average number of surgeries per patient was 1, whereas in the later time period, the average number of surgeries per patient was 1.5. And as you can see here, in the earlier time period, only 1.3% of patients had 2 or more procedures, and currently that's over 30%. So not only are we starting to stray away from doing fistulotomies, but we're also doing multi-stage or multi-step procedures in a number of patients. So looking at this data, it may make you wonder why we are starting to step away from, or we've seen a decline in a procedure that really has excellent rates in terms of clinical resolution and has a relatively low recurrence rate, yet we're doing it less. And I would say that the reason is for the third goal of fistula surgery, which is to preserve sphincter function. This table lists a number of studies that looked at fecal incontinence, and while once again there's significant variety or variation in the number, anywhere from 3.8% to 51% in terms of incontinence, most studies demonstrate somewhere around 30 to up to 50%. Now, one of the reasons for the difference is because what you define as fecal incontinence varies in these studies. There was a study by Kavanaugh et al., which once again looked at their retrospective review over a 10-year time period. They had 138 patients, and they used a validated survey called the Fecal Incontinence Severity Index. Their follow-up was 26% had less than 2-year follow-up, 39% were between 2 and 5 years, 30% between 5 and 8 years, and 5% were greater than 8 years. And I illustrate this just to demonstrate that this is a study that really has long-term follow-up. In terms of type of fistula, 41% were intersphincteric and 59% were transsphincteric. Of note, the patients who had transsphincteric, the majority of them had involvement of less than 1/3 of the sphincter complex. They found that 36% of patients had a FICE score of 0, which is perfect continence. However, 47% had complete 47% had complete continence to gas, 76% to mucus, 62% had complete continence to liquid stool, and only 72% of patients had complete continence to solid stool. When they looked at restrictions of lifestyle, about 25% of patients had either mild or moderate restrictions to lifestyle. When they looked at factors associated with fecal incontinence, they found that the type of fistula and the percent of external sphincter involvement were significant factors in increasing the rate of incontinence. Once again, looking at the study by Dr. Garcia Aguilera, in their study, 40% of patients stated that they had some type of fecal incontinence. The majority of these patients were incontinent to gas or had staining of their undergarments. But 13% of patients did have incontinence to solid stool, and almost 30% of the patients that they looked at stated that they had to wear pads. When they looked at factors contributing to increased rates of incontinence, they once again saw that as the complexity of the fistula increased or changed, so did the percentage of incontinence. Now, in terms of treatment, in this group, there was a significant difference in that patients who had a C-TAN and then a fistulotomy actually had higher rates of incontinence. The authors concluded that that was because these tended to be more complex fistula. When they looked at univariate analysis, they found that sex, fistula type, the treatment, the percent of external sphincter involved, and previous fistula surgery were all significant. On multivariate analysis, the percent of internal sphincter involved also became significant. I wanted to highlight this study because this was a study that only looked at patients who had intersphincteric fistula and ano. Now, I think that most of us would agree that this is a patient population that traditionally we have felt was acceptable or could undergo a fistulotomy because very little of the sphincter complex would be compromised. They prospectively examined both functional and manometric results in 275 patients with chronic fistulas. 191 of the patients had intersphincteric fistulas, and fistulotomy was done in 198 patients, with 168 of them having intersphincteric fistulas. They excluded patients with multiple fistulas and those that underwent cutting C-TAN fistulotomy. So the total group that they looked at was 148 patients. They had a median follow-up of 12 months and a relatively low recurrence rate of 2.7%. Interestingly, 20% of patients complained of some degree of incontinence after surgery. 6 patients reported staining of their underclothing. 27 patients reported incontinence to flatus. 4 patients incontinence to liquid stool, and 0 patients had incontinence to solid stool. However, postoperative incontinence scores were significantly higher than preoperative scores. Maximum resting pressure significantly decreased after fistulotomy, and as you would expect with none of the external sphincter muscle cut, the voluntary contraction pressures did not change. Now, once again, I highlighted this because this is traditionally a patient population that we feel can undergo fistulotomy with really very low chance of incontinence, and that doesn't appear to be the case here. When they looked at factors affecting postoperative incontinence, they found that the only significant factor was preoperative voluntary contraction pressures. So the lower the preoperative voluntary contraction pressure, the higher the risk of fecal incontinence. On multivariate analysis, they found both previous drainage surgery and, once again, preoperative voluntary contraction pressures to be significant. So in other words, if patients already had compromise of their external sphincter, then they were unable to compensate for the loss of the internal sphincter once they had the fistulotomy. Now, there are 2 groups that I just want to touch on quickly because these are often excluded in the studies that I've presented. The first is Crohn's disease. So 25% of patients with Crohn's disease will develop an anal fistula at some time during the course of their disease. It is the most common anorectal manifestation. Fistulotomy for complex perianal fistula has resulted in non-healing and incontinence in up to 40 to 60% of patients and may result in the need for either diversion or proctectomy. There was recently a study that looked at surgical treatment for fistula and ano, and they had a consecutive series of patients operated on over an 11-year span. They excluded patients with fistulas due to cryptoglandular disease, HIV, pouch fistula, and rectovaginal fistula. All patients in this series underwent an initial incision and drainage of their abscess, and when needed, had a ceton placed. Medical management was optimized, and only when there was no evidence of active Crohn's disease or proctitis did they undergo surgical treatment or definitive surgical treatment with a fistulotomy. They had a mean follow-up of 79 months. In total, they had 362 patients, but 301 of them were excluded due to the etiology of the fistula, which left only 61 patients operated on for fistulas due to Crohn's disease. Of those, 37 patients had definitive surgical treatment, 28 of them with a fistulotomy and 9 of them with an advancement flap. In terms of recurrence rates, there were 5 recurrences in both groups, but I'll have you note that the patients that had an advancement flap had more complex fistulas. When they looked at incontinence both on 2 different validated scores and compared it to the incontinence they saw with cryptoglandular disease, as you can see, it was significantly higher in the patients who had Crohn's disease for every factor that they looked at. In terms of HIV, there was a study that looked at 60 patients, 31 of whom were HIV negative and 29 who were HIV positive. These patients all had intersphincteric fistulas, which were treated by fistulotomy. And as you can see, the mean time to healing was significantly higher in the HIV population. In those that were HIV negative, there were 0 that had an absence of healing, whereas in the HIV positive, there was almost 23%. Again, this is significantly different. In summary, successful healing has been reported in 87 to 100% of patients undergoing fistulotomy for fistula and ano. However, rates of recurrence and fecal incontinence have been described in up to 50% of patients. I would suggest that alternatives should be considered in patients who have involvement of most of the sphincter complex, in patients with HIV or Crohn's disease, and in patients with multiple simultaneous fistulas, multiple previous surgeries, or evidence of decreased sphincter tone. Thank you very much for your attention.